Hello, good morning, good afternoon to those who are joining around the world. We have a very special Instagram Live today. We are being joined by Dr. Mona Orady, who is an MD, FACOG gynae surgeon who has her own practice specializing in endometriosis, which is very, very relatable and timely given it's Endometriosis Awareness Month, and courtesy of about diagnosis, treatment, surgery, testing. So please do join as she answers questions live. Hello, welcome, Dr. Orady.
Hi,
How are you?
how are you? I'm good. I'm between
We
surgeries,
are We
so
are very privileged to have you here today. Obviously, your specialism is women's health and endometriosis, and you are well known in the field for obviously having your own women's health clinic, but also non-invasive gynecological surgery too. So it would be great to hear a bit about you, your specialisms, and your involvement in the Endometriosis Society.
yeah, sure. So I'm actually Canadian. So I did my medical school and my training in Canada before I came to the United States, where I started specializing in minimally invasive surgery and robotic surgery, about 20 years ago. And I became very involved with the Society of Laparoscopic and Robotic Surgeons, and was the director of robotic surgery at the Women's Health Institute Center for Endometriosis and Fibroids at the Cleveland Clinic for several years. And that was really where I started focusing on endometriosis and changes in treatment for endometriosis, because as we've discovered that the traditional treatments for endometriosis, I call them band-aid
Hmm.
treatments, birth control pills, or doing a laparoscopy and like burning endo or giving Lupron or things like that, are just temporary treatments for endometriosis. But the true gold standard kind of definitive treatment, especially for patients who are trying to get out of pain or seeking fertility, is actually excision of endometriosis, where we go in minimally invasively and carefully, gently remove the abnormal endometriosis tissue, and try to preserve and restore anatomy so that we can take away patients' pain but still preserve their fertility, or actually enhance their fertility and the ability to get pregnant through this kind of microscopic, very delicate surgical procedures that I like to use: either microlaparoscopy, which is laparoscopy with tiny 3 millimeter incisions for milder cases, and robotic surgery with a laser for extreme precision for more extensive, kind of deep infiltrating endometriosis. And honestly, it is just amazing the results that we see here at the Orady Women's Clinic. Patients are out of pain. They get pregnant after years of not being able to get pregnant.
Wow.
They say it's life changing, and it's just really what keeps me going. And I travel the world giving lectures. I'm part of the Endometriosis Summit every year. I'm the president of SLS, or the past president now of SLS, and I'm always trying to push the field forward and have more people talk about this, because it's a poorly diagnosed and poorly treated disease, unfortunately, despite the fact that it affects 1 in 5 to 1 in 10 women. So everyone knows someone with endometriosis. Most people don't know that they have
Absolutely.
endometriosis.
And how do patients normally come to you? How do they, where do they get referred from for initial steps to seek help?
So various sources. I mean, mainly the most common is word of mouth. Friends tell friends. I have all these girlfriends that have a lot of pain or struggling with fertility, or like fertility groups. And so they just tell them, oh, just go see Dr. Orady, she'll figure out what's wrong and fix it. I do get a lot of referrals from fertility doctors themselves, from fertility centers, where people are either failing implantation, failing treatment, recurrent miscarrying, and they send me those patients. And then I get a lot of referrals from gynecologists for patients who are having either infertility or chronic pain or fibroids or other issues that need, fertility preservation. Those are kind of the three main sources, but also people who listen to my talks or my lectures will also reach out and fly into San Francisco to have, to be evaluated or have surgery as well.
Of course. And do you often see patients whose kind of symptoms, I guess, are recurrent loss, and then under a laparoscopy they get now diagnosed with endometriosis? We've seen some research between endometriosis and miscarriage. Can you tell us a bit more about that?
Yeah, I mean, there's this myth that people with endometriosis that can get pregnant, that it's not endometriosis that's causing their issues, which is actually a
Okay.
myth. Endometriosis affects all aspects of pregnancy. It can affect the ovarian quality, ovarian egg quality. It can affect fallopian tube function. It can affect implantation. It affects recurrent. It can cause miscarriage. So it affects every aspect of the pregnancy process. And the myth of, if you got pregnant then it's not endometriosis, that is not true. The other thing is that endometriosis is often associated with Mullerian anomalies. So patients with endometriosis may have a small septum or an arcuate uterus or abnormalities of the uterus itself, adenomyosis, endometritis, other things that can contribute to
Mhm.
recurrent miscarriage that we can treat as well with hysteroscopy or other treatments. So whenever I see a patient, I assess the whole system, right? The ovaries, the tubes, and the uterus. So I never just do an endometriosis excision laparoscopically without also doing a hysteroscopy to assess the uterus and fix anything that's wrong there, as well as a cystoscopy. So,
Mhm.
and I think that's unique to me. And I'm actually trying to gather my data because the rate of uterine anomalies that I've been seeing has been at least 10 to 20%.
Wow.
Most of them undiagnosed
Okay.
in the patients with endometriosis, and same within the rate of ureter and bladder abnormalities are extremely common, which again would not have been diagnosed had someone not looked. So I have over, just in San Francisco, I've operated on more than 1,000 patients. So I have a cohort that I want to start publishing so that I can encourage other endometriosis surgeons to look in the bladder and the uterus when they do an endometriosis surgery, because it's very common
Hmm.
to find other things at the same time of the endo surgery.
Absolutely. A word that we hear repeatedly in the fertility community is silent endometriosis, if that is the right word. Is that something you've heard of? And do
Yes.
you see patients who have experienced miscarriage alongside silent endometriosis?
Yeah, so I don't like to use the word silent endometriosis, but people do come to me. To me, it's undiagnosed
Okay.
endometriosis, right? It's not
Okay.
that it's silent.
Yeah.
If you actually ask these patients about symptoms, you will find that they have symptoms or had symptoms in the past. They just didn't know they were endo. A lot of them have quote unquote IBS, quote
Right.
unquote, I wake up at night to pee, quote unquote, discomfort with intercourse. And a lot of people don't know that those symptoms are actually endo symptoms.
Wow.
Had
Yeah.
pain before periods, between periods, around ovulation. Maybe they don't have the classic dysmenorrhea or painful periods, but they have other kind of symptoms. I've seen a few patients that maybe, when I ask them, they don't really have any symptoms, and those are, quote unquote, silent endometriosis. But to me, it's undiagnosed endometriosis. And if you actually look at the literature, just by virtue of having infertility and going to a fertility center, that alone puts you at a 50% risk of endometriosis. If you've had an implantation failure or a miscarriage, that risk goes up to 60-70%. Add on an abnormal physical exam, meaning their uterus is shifted, it's tilted, the tilted, classic tilted uterus, right?
Yeah.
Or the tilted cervix.
Yeah.
Now it's 80-90% chance you have
Wow.
endometriosis. So it's like, by the time they get to me and I go through the whole history and physical exam, I'm like, it's not silent. You have endo, it's for sure. Like almost 90%.
Is that the same as a retroverted uterus?
Retroverted, and more important than retroverted is the shifted left or right,
Okay.
because we are born with our uterus in the center of our body, just like we're born with our liver on the right and our heart on the left. Our uterus is in the center, so something is pulling it left or right. That is not a normal position of the uterus. Retro or anti normal can happen. 20% retro, 80% anti, but severe retro, where it's like flipped all the way, that's not normal.
Okay.
Or severe
Really
anti,
good.
right, that's,
Really good for people to know about these things to look out for.
yeah.
In terms of testing, diagnosis, how would that normally happen with undiagnosed endometriosis?
I mean, history and physical exam, obviously I'm Canadian, that's the most important thing, is history and physical exam by an expert. Ultrasound, in order to detect kind of areas by an expert, again, who knows how to look for findings related to endo. And then the Receptiva diagnosis biopsy is a very important way for patients who really have no other findings or we're not really sure if endo may be impacting their fertility. It has, up to an 87 to 97% accuracy in terms of endometriosis. And for those patients that I receive as a Receptiva positive, and to date, I have never found someone who did not have endometriosis when I did their laparoscopy. So it is a nice diagnostic test for people who we're kind of on the fence with. We're not sure they have endo. Should we really put them through surgery or not? This way helps us to kind of triage those patients, rather than putting them through surgery and not finding endo. This kind of gives us that reassurance. Yes, there's endo there and you should go get it.
Could you explain a little bit more to people who have not heard of the ReceptivaDx testing and BCL6 testing, exactly how it works and what you find from it?
Well, it's a very simple test. It's a biopsy of the endometrial lining that's performed day 7 to 10 post ovulation, which is the time that really the embryo is implanting and babies being formed, to see if there's this marker of inflammation called BCL6 that's elevated. And it's been found that with this marker of inflammation being elevated, that the likelihood of endometriosis is extremely high, and the likelihood that a pregnancy will stick is low. So the BCL6 actually predicts poor outcome, implantation failure, miscarriage, etc. So the fact that this test is predictive is a good test to do before you implant an embryo or try to get pregnant, especially if you've already been having trouble, because the result can sway you to finding endometriosis when it is quote unquote silent. Obviously, if someone has symptoms and is in severe pain or things like that, we already know they have endo and they would benefit from surgery just from a quality of life perspective. And then a lot of studies have showed double to triple the live birth rate after surgery as before surgery.
Wow.
So we can improve your fertility 2 or 3-fold just by performing a good endometriosis excision by an expert surgeon.
So if someone has a BCL6 test through ReceptivaDx, what would happen if they tested positive? What would be the next course of treatment?
They should see an endometriosis expert to discuss the risks and benefits of performing endometriosis surgery, or the alternative treatment, which is treatment with Lupron, which is a medication that creates an artificial menopause to turn down the hormones and suppress the endometriosis. And there's risks and benefits to both approach. Obviously, the risks of Lupron is it's a medication, it has side effects, it has to be used for 2 to 3 months, and then it takes some time for that to get out of your system. And it only suppresses the endo, it doesn't actually remove it. So that endo can reactivate once you're off the medication. The advantage of surgery is we remove the endo, so it should not come back. Or if it comes back, it doesn't come back quickly. And we know it's there, we've seen it, we know where it is, we removed it all, and it'll mitigate a lot of the symptoms that patients have that they don't know they have, like the painful intercourse or urinary symptoms, or bowel symptoms, or bloating. Like a lot of patients have symptoms and they don't even know that these symptoms were endo, or they feel better and they don't know why until after the surgery. And they're like, wow, I didn't know I was living that way until after the surgery.
Yeah. Someone has just said the majority of endo specialists are of the opinion that surgery or Lupron has no effect on IVF outcome. What would you say about that?
Absolutely not true. There's very many studies that have shown positive, as I said, double or triple the live birth rate by performing surgery. Lupron has similar improvement in implantation. It doesn't show improvement in natural pregnancy rates.
Okay, this is really helpful to know. Thank you so much. I'm also aware of your time, and we'd love to do a round 2, follow up with you for more questions, and to talk all about endometriosis, and also the Receptiva DX test, BCL6. How can people ask for this test with a physician?
I mean, they should, I think the Receptiva website has the locations of physicians that are performing the test. They should also ask their fertility doctors and maybe gynecologists that are interested in fertility. It's not commonly available amongst general gynecologists. I perform it because at least 50% of my patients are fertility. The other 50% are pain. So I offer it because I have so many patients.
Yeah.
A lot of patients have already come to me with a positive test from their fertility physician. So that's who I would discuss with them to see if it's available or if they can get it done.
And these patients that you're talking about, may they have had symptoms or no symptoms for many years before they have the testing done through you?
Oh, many.
Mm.
Most patients' endometriosis starts at the average age of onset is age 14, and it
Wow.
can be younger. So by the time I'm seeing patients, they're in their 20s and 30s or even early 40s, and they still don't know they have endometriosis.
Mm-hmm.
So
Mm-hmm.
it's actually a testament to how poorly our education system has educated how to diagnose endometriosis.
Mm-hmm.
Women can go the majority of their life without ever knowing that they have it.
So when patients come through the door, who would you decide should have this test done?
It's mainly when I'm on the fence, kind of.
Okay.
Most patients come to me already knowing or thinking they have endo, and we're going to do the surgery anyway. So it's not going to change my management. So there's no benefit to the test. But
Mm-hmm.
for patients where we're not sure, or it's going to sway us one way or the other, or change our management plan, then it's worth doing the test. Otherwise,
Definitely.
it's not. If we do the laparoscopy and there's endo, no need for the test.
Mm-hmm.
So it's for the patients that you're really not sure or want a confirmation before they do surgery that this is what's causing their fertility issues or problems.
Okay. Two more quick questions for you. How many women seek your help with this unexplained infertility or no symptoms diagnosis? Would you say the majority?
I think it's increasing,
Okay.
right? As education is increasing and patients are talking to each other, I probably see a patient with Receptiva positive almost every day. And I probably see 20 endometriosis patients per clinic and probably 20 new patients per week. So
Mm-hmm.
it's definitely out there and the numbers are increasing, but I think it's because of events like this where women start talking to each other,
Absolutely.
something that is kind of commonly available or even known amongst fertility doctors or gynecologists. And this is
Yeah.
what our discussions and the endometriosis summit and SLS and all the lectures that I give and the research that I do is trying to kind of improve the treatment. But it is a relatively new test. It's been around only a few years, and I think that that a lot of people just don't know about it yet. But I
Mm-hmm.
think the numbers will increase.
But as you said, it's about people advocating for themselves, being well educated in the right spaces. This is why, we love working with ReceptivaDx to educate women on these options and what to look out for and how to test, etc. So you can be an advocate for yourself. And having conversations with specialists such as yourself is really empowering, whether it's Endometriosis Awareness Month or not. It's super helpful and gives people options.
Absolutely. Absolutely. And it's actually like kind of really sad to me that by the time women get to me, they internally have known they have endo for a long time or
Mhm.
that they're not normal. But a lot of them have been gaslit and, denied their, and been told, oh, no, you're fine. There's nothing wrong with you. Or, your pain is normal or, kind of minimizing their
Mm.
symptoms. And it's really sad. And as a woman, I'm always saying you have to advocate. You have to, if someone's not listening to you, you need to hear, you need
Mhm.
to be heard. So find a doctor that will hear you and listen to you. You are not crazy. It's not all in your head. That you need to be listened to. And if you have a gut feeling that there's something wrong, then there's
Yeah.
something wrong. Well, who is it? Who's someone else to say that what you're saying is not
Uh-huh.
true? And please don't give up and
Yeah.
kind of take it and live on. You should have a good quality of life. You should be able to have a baby. And we need to get these diagnoses earlier and earlier
Mhm.
so that women aren't suffering for years and years before they finally find treatment.
Amazing advice, Dr. O'Reilly. Thank you so much. So avocation, absolutely. And I urge people, if you feel that you may have endometriosis or want to, start conversations, investigations, please do head to our link in bio, find out more about the Receptiva DX test. And also, if you'd like to speak to a specialist, obviously they can put you in touch. But yes, please do follow our link in bio. And thank you so much for your time today. I know you have surgeries and a very busy schedule, so we look forward to hopefully catching up with you again very soon for part two.
All right. Thank you so much.
Thanks, everyone. Thanks. Bye-bye. Bye.